Thank you. So, as John just said, I've just recently joined the NCI. I was actually supposed to start on October 1st. That didn't quite happen. And because of my travel schedule, I've actually only been in my office for 3 days, so I'm definitely not giving the NCI view of the world quite yet. So we can have some patience here with me. So what I want to do is actually go through what I think are some policy issues that are facing all of us, and I think they really impact data sharing and how we go about information sharing from an informatics perspective in particular, but I think they really now, that means it really does impact every aspect of cancer research. So something, though, I want to bring up is that the issues that I'll discuss are really relevant for prevention as well as clinical trials and how we go about providing therapy. So I think this morning we were much more on the clinical trial and therapy side, but I think this afternoon we're going to be moving more and more into how we do prevention. And keep in mind that the issues I bring up are really relevant for both. So to me, one of the biggest problems that I see as an informaticist is the lack of a clear understanding of what informed consent really means, and having systems in place that when a patient gives informed consent, that we can actually properly track what that means and really respect the request of that patient. So I think there are some policy implications with that, and I think they're around how do we make informed consent a little clearer, how do we make it more informative, and then in many cases, do we really need informed consent at all to do the kinds of research now that we're talking about doing? And I'll go into that in some more detail. I think something else that's really come to the forefront, both with molecular data and now with really any kind of tissue-based data, is that it's all identifiable. And in fact, there have been a number of people who show that when you have more than 7 or 8 variables that are available to you from a clinical record, that's also identifying exactly who that patient is. So our thoughts about privacy and identification, I think, really do need to be rethought as a society, and what privacy and identifiability of data means. Then both of those have real implications for data access. So how do we go about making the data that we're generating accessible and mineable? All the really cool things we heard about this morning about the great systems biology and coupling of clinical data with molecular data require us to make those data available for people to do that mining. And right now we can't do that across institutions. We can't often do that between different trials. So how do we make data sharing much easier? So now I want to step back and kind of take you through the thought process of why I think these 3 things are so important, and also where information technologies is moving, I think, in the next 5 to 10 years. And I hate to predict out farther than 10 years because 10 years ago I wouldn't have thought I'd have a smartphone in my pocket that could do so many different things. So who knows what another 10 years is going to bring. But I want to start that with a discussion of disruptive technologies, what they've been. I think all of you are familiar with every one of them that I'm going to talk about. And again, talking about cell phones, now social media and the ubiquity of social media, it actually, I think, is going to transform the way we think about participation in cancer research and the way we think about being able to reach out into patient communities. I'll touch on what is big data, but I think that was discussed a bit more this morning. I'll leave it out for brevity. And then again, talk about what does it mean to have open access to data. So these are kind of the fun slides for me. So what are some of the disruptive technologies that we've seen in the last 1,000 years? The big one, of course, is printing. It dramatically changed our access to knowledge, and that's a great example. I think one that doesn't get quite as much attention is steam. So steam was the first time where the average person that had access to a steam engine had access to hundreds of horsepower of energy. And that really did transform the way that societies and industry was able to develop. So transportation did the same kind of thing, but with respect to distribution of goods. Electricity has let us now take energy and make it freely available everywhere. And again, that's enabled an enormous amount of transformation in our societies. Antibiotics, that was now moving to less than 100 years ago, we've been able to dramatically impact the longevity of life, now directly due to medicine. So now I'm getting closer to the point that I want to get to, and that's that semiconductors and VLSI designs have dramatically changed the kinds of devices, access to information that we all have. And I think this is really a foundation of a lot of things we've been talking about today certainly with systems biology. The internet itself and HTTP has really dramatically changed the way we think about even things like printing. So now we have access to information, and it's easy for us to access that information. And now high throughput biology. We now can generate enormous amounts of data on single cells, let alone whole organisms. And I think Andre had a different take on this morning, but I would say it almost exactly the same way, and it's the end of the reductionism that we've seen. Now we can start to assemble things back together. We get a full systems view of what is biology, what is cancer. And then, as I mentioned before, mobile devices. So now we have ubiquitous computing. And I looked up how many active mobile cell phone contracts there are in the world today. It shocked me. It's 6.6 billion contracts are out there. That means roughly more than three quarters of the people on the face of the earth have a cell phone. And a full quarter of us have some kind of smartphone contract. Those are huge numbers. In contrast, just a billion people, that sounds like a lot, or a billion landlines are in place across the planet. So we now have in our pockets an enormous amount of connectivity and computation. And I think this gives us an ability now to change individuals' behavior. So for instance, as I was getting ready to walk up here, I wasn't expecting this. My daughter uses my phone sometimes, and she plays a game called Kitty Cat Jump. And I got a text from Kitty Cat Jump saying, "You haven't played me in a couple days. You should really get on and play." If we could harvest that kind of experience to say, all right, you haven't gone out and you haven't taken your medicine yet today. You really need to go take your medicine. You need to go out and exercise. You need to go out and don't eat that Big Mac today. Go out and have something healthy. If we can harness these devices to actually, from a prevention standpoint, we have a tremendous opportunity to change people's lives. Or you could play Kitty Jump. So I think these are all comments I've already made in different ways. But one of my points to big data and to social data is we need to find ways to make them accessible to all of us, or at least make them accessible in a way that we can get the information we need to make good decisions and good analytics available on outcomes for cancer patients. And I won't go into big data because I think, again, it was discussed quite a bit already this morning. But from my perspective, we want to be able to combine social data with things like all the omic data, the next-gen sequencing data, with clinical care data, with outcomes data, and really be able to use all those sources to be able to answer important questions in oncology. So what's the future look like? There's, I'm sure, I guess for the folks that are are in the informatics field, I'd be remiss if I didn't mention elastic computing and clouds. I think that that's now become a social buzzword. I think that so many companies now are coming out with their cloud solutions for this and that, and it's become a little bit confusing exactly what even a cloud means. From the social network standpoint, again, that's something everyone knows what Facebook is. I'm probably one of the few here in the audience that doesn't have a Facebook account, and that's deliberate. But big data analytics, again, it's how do we mine all this information? How do we bring it all together? How do we make it actually useful to us as oncologists, as people who are practicing either oncology or cancer research? And again, this morning we've heard a lot about precision medicine, something I haven't heard anyone talk about yet because we haven't got to the prevention side is how do we measure health? So how do we measure how much reservoir of health do we have before we end up getting disease? And that's something that people are only now starting to discuss. And then how do we practice protective medicine or prevention? And I think, again, as a number of people this morning mentioned, that it's much easier to stop someone from getting cancer than it is to intervene and ameliorate the disease after it's occurred. And then the last point I want to make here is that what we really need to have is every place that cancer patients go, we need to be learning from that experience. And again, I think that's been said a number of different ways, that we want to be able to bring patients into or get information from every patient that goes into a hospital, into a community practice, and understand what their outcomes were and how they responded, and as much data as we possibly can on that. So now back to some of the policy issues. So from a policy standpoint, how do we need, or how can we help people gain access to all this data that we're all generating? And something I feel very strongly about is if we had access to more and more data, and most people had access to that, more access would mean more innovation. So more eyes on the problem would solve the problems faster. And right now, we're still stuck discussing what does it mean to have privacy, how do we build better mechanisms for providing people with these data in an appropriate way. And likewise, again, there's lots of buzzwords here. So precision oncology, I like as a term. And I think, again, precision oncology is really predicated on integrating data from all these different sources and having as much semantically defined data on patients as we can as we go about treating them. And something that, again, I think is very important, and I've heard echoed a number of times this morning, is being able to properly stratify risk on patients is very, very important as well. So how do we do that if we don't know who they are when they come in the door? We really can't. And I guess the real question in my mind is how do we re-engineer the existing translational research policies that we have that truly enable this learning healthcare system that I think is something we want to be able to work toward. And I've heard people talk about that as a learning healthcare system. Isn't that research? And I think it is, but it's a different kind of research than what we've traditionally done. And again, I think that's an important part for us to grapple with, both as a society and potentially for this forum to grapple with, is what does research mean in a learning healthcare system, and what does consent mean? So I already went through consent, and I think I'm pretty much out of time here anyway. But I already mentioned this point. Is there a way for us to imagine doing some of the things we're currently doing without consent in place, and what does that mean? Particularly for some of these, for being able to understand the data that's coming from so many patients around the country. and I already went through the identifying information, and I won't go through that anymore. And I am, though, happy to take your questions.